Dear all, welcome to our 35th peculiar case series in renal transplant. And those who are joined late, actually, new to this forum, this is a forum which brings up the peculiarity in renal transplant, and to know about the nuances of managing the cases, and to witness the peculiar cases, and thereby making us to reach the holy grail of healthy, lesser immunosuppressed, and a good graft function. We used to have 2 cases every month in order to explore the peculiarities of renal transplant, which were unnoticed before. And this forum was started along with Dr.Vel and Arvind 2 years back, and 2.5 years actually. And we are going without any break till now. And this is our 35th meet. And no wonder this forum has gained a much importance across India, and we have many foreign delegates also joining us in our WhatsApp group. So this meet, we have 2 interesting presentations by 2 eminent speakers, and who are all not new to this forum, and ably assisted by by 2 panelists. And first to introduce the speakers, Dr. Sanjay. He is associate professor of Siddharth Medical College, and also a consultant nephrologist from Subna Hospital, Bangalore. And he has number 1 in many credits, and many number 1 in his credits, like first ABO transplant in Karnataka, and oldest donor in Karnataka, and the first swab transplant in Karnataka. He has he is pioneered in many of the difficult transplant situations in Karnataka. And he has many papers of publications, and the interesting thing is he's going to present a case which he presented in 2015, I think so, regarding the comparison of the once daily dose tacrolimus with the conventional tacrolimus dosage. I think your presentation will give us more take-home messages, and it is a new area to explore. Actually, not many of us has tried once daily dose tacrolimus, so delegates must be benefited by your presentation, sir. And we have a second presenter, Dr. Pani Gopalani, probably my contemporary, because we used to discuss a lot, and he's a man of wisdom, actually. He did his master's all from England, and he has did his PhD in autoimmune disease, and he's one of the peer reviewer. He's a peer reviewer for many journals like CJASN and GK. Right? So his clarity of thoughts, and he's not new to this forum. He has presented 2 or 3 times before, and his prior presentation, and we have executing the management is all tremendous. And hope we'll be looking forward to hear your presentations. And this presentation going to be regarding the BK virus, and which is nuances tend to, at least for many transplant nephrologists, how to manage this kind of BKV. Many times it settles with lesser immunosuppression, many times it won't, and we need to give an antiviral. That also many times we succumb to the disease severity. And hope he will give more insight into the BK virus nephropathy. Probably we haven't discussed many things in our previous forums. We haven't discussed much about BK virus, so hope to learn a lot from Dr. Pani Gopalani. And 2 panelists, I'm very happy to introduce Dr. Rushi Deshpande from Mumbai, actually. Sir, welcome to our meet, sir. Actually, this is, we haven't have a panelist from Western side, actually. And when we contacted Dr. Umesh Khanna, and he told that I'm not fully into transplant. And I asked him whether to suggest somebody who is doing transplant in Mumbai. Immediately, he suggested your name, actually. And Sir is director of nephrology from Jaslow Hospital, and is most interested in ABO and comparative transplant and many complex renal transplant. Hope your inputs will serve much to this meeting, and we hope you to hear from you, sir. Joining him is Dr. Ram Prabhakar. He is also not new to the forum, and he has also presented, and he has been orator in 1 or 2 sessions, and he's from SWIMS Hospital, Chennai. And he's passed out from 2004 MMC, DM nephrology, and he's known for his presentations. He's a very good, voracious reader, and his deep fundamentals, basics, his fundamentals are very good, and hope he will be giving a lot of his inputs also. Without wasting much of our time, I'll ask Dr. Sanjay to start his presentation. Over to Dr. Sanjay.
Yeah, I'll be sharing the screen.
Yeah.
Okay, good evening to all. First of all, I thank Dr. Rajan for having given such a nice introduction of mine. So today I've been asked to present my data on once daily TAC in comparison to the conventional BD TAC. And if you see, the once daily TAC was almost launched more than a decade back in India. We had a lot of hopes that there will be many switchovers or many de novos, but somehow we have not been using ODTAC, more effectively or more efficiently, I would say. Now, this may also be the fact because we are in our comfort zone, because the BDTAC has done so well as far as the renal transplant is concerned, where first year survival is more than 95% in almost all the centers, and rejection rates being very low with the induction. But if you ask me, is there still a need for once a day tacrolimus? Then I would say yes, there is a need, because once a day tacrolimus potentially improves the inter and the intra-subject variability that we see with BD-TAC. It improves the compliance because we are going to use it only once a day. And there is a therapeutic equivalence when you compare this to the conventional tacrolimus, and therapeutic monitoring for both remains the same. We in our clinical practice would have definitely come across patients who would have been doing well over months or years, and suddenly one day they present to you and they said that the creatinine had gone up. And invariably they would have done the creatinine themselves. So that is where we find that it is most probably the non-adherence that the patient might have had to the drugs. Now, if you look at non-adherence, it may be accidental where he might have forgot, or it may be invulnerable where he believes that missing 1 or 2 doses may not harm him, or it may be a more difficult form called as decisive where he wants to stop the drug, whatever the outcome may be. So if you look at this paper which came out by Solaris Group, and in 2012, they wanted to know what was the causes for kidney transplant failure towards the later part of the transplant. And they found that almost 64% of these patients had antibody-mediated rejection individually, which was 50%, and in combination as a mixed rejection in the rest 5 to 10% of the cases. Now they looked what was the cause for this, and then they looked at this cohort. They found that the non-compliance was responsible for this in about 47% of these patients. Now, if you look at this data which got presented in AJT, here also you see that the non-adherence, if you see, usually starts after 1 year in majority of our patients. This is when the patient is doing well and they start developing the confidence that they are doing well, and then the doubt comes in. Is there a need to continue the medications the way it has been suggested? And you see, if there is a non-compliance, the late AR-free survival significantly reduces, which is shown in the blue line. Now, if you look at the non-adherence, many papers has been put forward, and they have reported it anywhere between 20% to 30%, leading on to almost 17% graft losses in 15 to 20% graft losses in majority of the studies. And you look at the commit guidelines, the consensus on managing modifiable risk in transplant, they suggest that non-adherence to immunosuppressive agent is a modifiable risk factor which we should strive upon to prevent later losses of the graft. Now, if you look at the graft survival for patient with low and high intra-patient variability, now I have been talking to you about the non-adherence of the patient. Now, the second problem that we find with this BD tacrolimus is that there is a intra-patient variability. That is, within the patient, there is a variability in the levels. And if you look at this graph, the graft survival patient with the low and high intra-patient variability, if the variability is low, then the possibility of the graft survival is much higher compared to those patients where the fluctuations is much higher. And they have also seen that the intra-patient variability varies from time point. At one, for example, if you are looking at maintaining the C0 level, if you are looking at maintaining the C0 level, you again see that you maintain the C0 level, but at some time point, there are jumps or there are reduction in the levels below that, or there may be peaks above the expected values. And these intra-patient variabilities may be responsible for the complications that we see among these patients. As you know that BD-TAC, we take the dose twice a day. So there are two definite peaks, and there are many times you see the levels going below, and there will be fluctuations going above the required levels. So there has been reports of issues with evening doses, particularly the TAC administration in the evening results in a delayed absorption, and there is a night dose which is the most frequently forgotten dose by the patients. With respect to the evening delayed absorption or low levels, I will be soon coming out with data where I have compared the TAC levels for the morning dose as well as the evening dose in the same patient on the same day. And very soon I'll be coming out with the interesting data on that if there is a evening variation in our patients in Indian scenario. So with all these variability, the concept of once a day tacrolimus came in that it potentially improves the inter and the intra-patient variability, potentially will improve the compliance because it's a once daily administration and it has a therapeutic equivalence and with the same therapeutic monitoring probably gives a better outcome in the patients. Now, once it was introduced, they wanted to know whether really once a day was equivalent to the twice a day formulation. And this study, which came out in way back in the late 2010s, now it showed that there were therapeutic equivalence and there was a similar efficacy, comparable safety between both the drugs. Now, this I'm putting out, it's a single center study, but again, it showed the same that both were comparable. But why I have put up this is that they found that once you are using once a day tacrolimus, then there was a better lipid metabolism in this group. And if you are looking at the area under the curve and the pharmacokinetics of the drug, they found that the Cmax with Advagraph was much lower compared to the BD dosing. And there was a steady state, which was area under the curve with less fluctuation, which may later lead on to a better compliance, compliance in its OD, and also better outcome of the grad because of less variations. So with this in mind, we wanted to see what happens in our patients in Indian scenario. So we look. This got published in 2023, our study, and basically that study looks at the retrospective analysis of the data from 24 continuous patients on de novo OD-TAC and 24 continuous patients on de novo conventional BD-TAC. So protocol for immunosuppression was same in all. It was, I start my patients on 0.1 milligram per kg per day, starting -5. That is 5 days prior to the transplant, so that I get my levels on the day 0. And the advantage that I am not erring on low dose or the high levels of this of the tacrolimus on the day of the transplant, which might impair the early graft outcome. The mycophenolate mofetil is given at 1 gram per day, and steroid is given previous day at 0.5 milligrams per kg. The regular protocol, 1 gram methylpred at clamp release, 0.5 the second day, the third day at 250 milligrams, the fourth day 0.5 milligrams per kg orally prednisolone, then 20 milligrams fifth day, then reducing 2.5 milligrams every week to reach a baseline of 7.5 within 1.5 to 2 months. I tend to keep my TAC levels little low. It is 6 to 8 nanograms per ml post-transplant, immediate post-transplant, and then trying to maintain it around 3 to 5 nanograms per ml by the third month. MMF is increased to 1.5 grams. It is a mismatched transplant like spousal, or if it is a cadaveric transplant, and biopsy is done for any doubtful unexplained increase in creatinine. So if you look at the comparison of the data that we have, the general parameters of both the groups, whether it is OD or conventional tag, they were all comparable, whether it was the age, the type of the donor. If you look, we had 13 spousal transplants on the conventional tag. Similarly, if you look at OD tag, we had 5 cadaveric and 6 spousal transplants, almost matching. The p-value was non-significant between the two. If you look at the details of the induction therapy, there was only one induction on the tacrolimus group where we used ATJ. Since the OD-TAC had patients with cadaver transplant, and since we were using the drug for the first time, so we thought we'll cover them with induction. So those who agreed for induction, we used induction. So totally one in the BD tacrolimus and 11 patients in the OD-TAC had an induction. So what were our observations? So the follow-up period minimum was 2 years. And as you see our data, the previous slide you would have seen here that the overall follow-up period was 42 months in mean follow-up period was 42 months in OD tag and 46 months in the BD tag. So what was our observations? So if you look at the last follow-up, the average weight was comparable. The last dose of tacrolimus was comparable. The average serum creatinine at the last follow-up is again comparable. And tacrolimus dose as a tablet and as per kg body weight, both are comparable and the p-value is not significant. So this is the comparison of the dose at the time of discharge to the last dose. That is the initial dose to the last follow-up dose. Again, both are comparable. Look at the average serum creatinine. Advograph group was a little higher at the time of the discharge. That is also because of the fact that cadaver patients were there in that. And if you look at the follow-up, what is happening, the Advograph has 1.2 average creatinine compared to 1.32, but p-value is not significant. Now we wanted to look at what happens to the TAC levels, which we did on the day 0. You look at the scatter plot, the red represents the BD tag compared to blue, which represents the Advograph. You see that Advograph group is more concentrated in almost a therapeutic range, where we want the drug levels to be. But if you look at the BD tag, it is scattered throughout. This is not we expect what we would expect out of a drug to be used for immunosuppression, saying that probably Advograph had a more stable effect and a sustained levels. Then we went on to look at PTDM and we were really surprised.
Raj?
Dr. Rishi? Doctor? Yes, sir.
I'm not
Dr.
able to hear.
Sanjay? Yeah, I'm not able to. Dr.
I
Sanjay?
think there is an interruption. I think we can't hear Dr. Sanjay.
Yes, sir.
I think his video is as well cut. I think it's not.
Yes, sir.
Ask Tangabandi to contact him.
Yes, sir. I'll.
Actually, he has left and joining, I think so.
I think he's facing some network issues.
Network issue, actually. Dear delegates, please bear with us. Actually, he is having some facing some network issue.
Sir,
Yeah, have you contacted
actually,
Tangaman?
yeah, yes, sir. Yes, sir, we tried to contact sir. Actually, he left without knowing that he is presenting the slides.
Oh.
Yeah. Can you please
Actually,
call him, sir? We called him, he's disconnecting our call.
I called him. Actually, it sounds busy.
Yeah. Without knowing that he is presenting, sir.
Yeah, I'm calling. He's getting the call actually.
Raj, wait for a second.
Sir, yeah, shall we ask Dr. Gopalini to start his presentation, sir?
Yeah.
Probably he's not picking up the call. Actually, he's cutting the call. Probably he's presenting without knowing that he's not there.
Maybe I'll try once again. Raj, I think it's better we can go with.
Yeah. So sorry for the interruption. Actually, his network is slow actually. So without wasting our time, we'll ask Dr. Pani Gopalini to go ahead with his presentation. Dr. Pani, are you ready?
Yeah, I am. You can hear me, right?
Yeah.
Okay. You can see my slides?
Yeah.
Thank you, Dr. Rajan and Dr. Vel Arvind for this opportunity. Sorry, it was a relatively late minute preparation for this, so apologies if it's not as slick as I would like it to be. So I titled this talk as Navigating the Waters, BKV nephropathy and renal transplant challenges. I see both the moderators have a lot of experience in ABO incompatible transplantation and transplantation in general. So I would be interested to hear their views as well at the end. This is not a very fancy case or anything as such, but I thought there are certain things that were done a little sort of out of ordinary, and maybe it's routinely done. I'm not very sure, but let's see what everyone thinks. So this case relates to a 37-year-old male. He was diagnosed with proteinuric CKD stage 5, presumed chronic pyelonephritis in the background. He was initiated on peritoneal dialysis in April 2022, which he continued on until June 2022. So for just a few months. And after that, there was his mother-in-law came forward to say that I would like to donate my kidney to my son-in-law, and it happened to be an ABO incompatible transplant. So mother-in-law was B and the recipient was O. The titers were 1 in 512, and there was a complete mismatch of 6/6. So he received rituximab 200 milligrams 2 weeks prior to the transplantation, and we went on to use glycosaminide adsorption. He received basiliximab induction therapy along with triple immunosuppression using TAC, mycophenolate, and steroids. The pre-transplant titers were 1 in 8, and the transplant went uneventfully. He had primary graft function, creatinine stabilized around 1.2 before discharge, and I targeted a tacrolimus level between 8 and 10 for the first 6 months. So the first 6 to 9 months were uneventful. Around 9 months post-transplant, he's developed acute GE. Creatinine increased to 1.51, and along with that, the TAC levels were elevated at around 13. So this was thought to be just a little bit of TAC toxicity, and the dose was reduced. This led to a prompt improvement in the creatinine to 1.2. Again, a month later, there was acute rise in creatinine to 1.5, and this time the TAC levels were low at 4.7. So the first question I asked myself is this rejection? So this was late in the day. So I gave him a dose of methylprednisolone and TAC dose increased. And the next day I brought him back for a transplant biopsy. And this shows mild lymphocytic infiltrates in less than 10% of the cortex. There were occasional tubules showing enlarged nuclei with suggestion of intranuclear inclusions, suggestive of viral cytopathic changes. There was also mild tubulitis. And C4D staining showed circumferential positivity in 50 to 60% of the proximal tubular cells, in keeping with ABO-incompatible transplant. And the SV40 showed nuclear positivity in less than 1% of the tubules, and this was classified as class 1 BK virus nephropathy. So in this context, I reduced the dose of mycophenolate to 180 milligrams BD from 540 milligrams BD. I also sent CMV PCR because there were some suggestions of neutropenia, and that was negative. And the BKV PCR came back at around 139,000 copies per ml. So the course is such that there was further rise in the creatinine from 1.6 to 1.75. In terms of the BKV nephropathy management, what I did was continued on reduced dose of mycophenolate at 180 milligrams twice a day. I increased the dose of prednisolone to 10 milligrams OD in the hope that I'm not going to subject him to acute rejection episodes. And the tacrolimus dose was adjusted to a level of around 6 nanograms per ml. And with this management, I thought I could probably win the game here. However, a month later, the BKV PCR sort of leapt up to 240 million copies per ml. So, just to summarize the clinical context here, this case relates to an immunologically high-risk post-transplant patient with 6x6 or 12x12 mismatch, and it is ABO-incompatible transplant. This patient developed BKV nephropathy, and the BKV titers were rising despite a significant reduction in mycophenolate dose and tacrolimus. So what are my options at this point? What are my options for short-term graft stabilization because the creatinine was rising? And what are the options for long-term reduction of risks of de novo DSA formation and TCMR, ABMR, whilst he's on reduced dose of immunosuppression? So at this point, I just want to talk a little bit about BKV nephropathy and then dive back into the case a little while later. So managing BKV nephropathy is like the English saying, between the devil and the deep blue sea. So you have devil on one side, which will not allow you to go to one side, and deep blue sea on the other side. So it's a very treacherous or precarious position. BKV is a polyomavirus family member. Majority of the general population would have had BKV in their childhood. And this virus remains latent in the renal tubular epithelial cells and urinary tract. When, for whatever reason, the immune system is suppressed, either because of immunosuppressive medications or acquired immunodeficiencies, the BKV gets reactivated. And this leads to nephropathy, which eventually leads to graft dysfunction and premature graft loss. A stereotypical pattern is seen in all of these patients. Initially, it starts with viruria. This is typically seen in up to 25% of transplant patients. And this is followed by viremia, which occurs in about 12% of KTP patients. And subsequently, this is followed by BKV nephropathy. So there is a lot of stress in terms of the guidance to try and monitor BKV in the blood, to try and understand if a patient is developing BKV viremia, such that you can adjust the dosages of immunosuppression prophylactically. Historically, BKV nephropathy was associated with the graft loss rates that exceeded 50%. Reduction of immunosuppression is the cornerstone of management for this. However, this comes with the risk of increased allograft rejection and ultimately graft loss. So the usual strategies that were employed to manage BKV nephropathy include typically reducing the dose of antimetabolite in the first place. If that's not helping, then stopping the antimetabolite, and that is followed by CNI dose reduction in case of non-response. There are no specific antiviral therapies for BKV infection, and the strategies are aimed at reducing the immunosuppression to clear the virus using the own innate and adaptive immune system. If associated with an acute rejection in these patients, pulse steroids may be considered. However, this strategy of reduced immunosuppression is fraught with much higher risk of rejection and graft loss. So just looking at some of these papers where they have sort of highlighted the actual risks of having BKV, it's actually quite bad. And if you look at this two Kaplan-Meier plots, on the left, you can see the death-censored graft survival in the BKV-associated nephropathy group is much significant compared to someone who did not develop BKV nephropathy. So this proportion of acute rejection was significantly higher in the BKV-associated nephropathy group compared to the control group, to the tune of 68% versus 12%. Further, This paper also showed the short-term graft survival was actually good. But when you start reducing the dose of immunosuppression, it appears you're actually winning. But the long-term graft survival is poor during the follow-up period, such that at 10 years, only about 37% of the grafts survive, as opposed to 50% in the other groups. So having BKV associated nephropathy in the short term may be okay, but in the long term, it is associated with poor outcomes. Also, this paper suggested that BK viremia is actually associated with development of de novo DSA. This paper looked at 785 kidney or kidney pancreas transplant patients, of which 17% patients developed BK viremia during the study period. After a median follow-up of 3 years, there was no significant difference in terms of the patient or allograft survival between the patients with and without BK viremia. However, persistent BK viremia was strongly associated with the development of class 2, but not class 1 DSAs. So this paper essentially suggests that having BK viremia it may or may not be causing nephropathy, but it definitely has got, it definitely increases the risk of formation of de novo DSA. Again, this paper summarizes the fact that development of de novo DSAs in renal transplant recipients with BKV is associated with immunosuppression reduction. So they have included about 190 patients that were BKV positive and 396 patients which were BKV negative. And then they prospectively measured or looked for the presence of BKV, and they called it as BKV viremia when more than 10,000 copies were identified in the blood, or the biopsy was suggestive of BKV-associated nephropathy. And they were also looking at the development of HLA antibodies in these patients. As you can see, in the far right sort of box on the right side, BKV positive patients, de novo DSA occurs in 22.1% of the patients, as opposed to someone who did not have BKV viremia. Similarly, the time to de novo DSA formation is much lower if they were BKV positive. And if they were BKV negative, this time is much higher at 434 days. So what are the other therapies? So it appears that the therapies that we're using at this point to treat BKV were suboptimal, and this primarily relies on reducing the immunosuppression and hoping that nothing else happens to the patient whilst we reduce these doses. So there were other therapies that were tried in this context, and they included IVIG, switching to everolimus, leflunomide, cidofovir, ciprofloxacin, virus-specific T cells, anti-BKV monoclonal antibodies. And the last two are recent developments which are being still studied. So I just thought in this context, I was going to explore the options that are available, because my patient has high immunological risk status. So looking at the impact of IVIG on the immune system, it seems to affect multiple components of the immune system that includes both innate and adaptive immune systems. In the innate immune system, it can inhibit the maturation and function of dendritic cells. It can block activation and modulation of Fc gamma receptors on macrophages. It can neutralize activated complement components. And again, it has got an effect on the B cells and its repertoire. It can neutralize antibodies. And also it has got some effects on the T cell compartment, whereby it can inhibit the inflammatory cytokines. So IVIG, even though there is no very one specific reason by which it actually acts, it seems to immunomodulate the immune system for the betterment of the patients. So what is the evidence of using IVIG as an adjunct in refractory BKV? So the proof is limited, and it's limited to case series, retrospective and prospective cohort studies. So there are no randomized controlled trials. As previously mentioned, it acts by interacting with Fc gamma receptors on dendritic cells, macrophages, granulocytes, and NK cells. There is also some suggestion that IVIG may contain strong antibodies that can counteract different strains of BKV. So the data is a little equivocal. In one study, they have shown a significant improvement in clearing viremia. Almost 90% of the patients that received 1 gram per kg of IVIG cleared virus with significant decrease in the viral loads at 1 year. However, another study actually showed completely opposite to this, whereby in this study, 52 of the 131 patients with high BKV loads received IVIG. At 1 year, the IVIG group had lower eGFR, and they also failed to show advantages in shortening the duration of BK viremia. So it is a little equivocal in terms of if IVIG is actually helpful from these two studies. However, this study, whereby they looked at about 50 odd patients, and one group received the standard therapy that actually included conversion of tacrolimus to cyclosporine, mycophenolate to leflunomide, they added oral ciprofloxacin and intravenous cidofovir. That is the standard group. The experimental group have received IVIG on top of the standard group. And you can clearly see from these Kaplan-Meier groups that the patients that received IVIG had BK viremia clearance much higher proportion of patients compared to conventional therapy. Similarly, on the biopsies, on the protocol-based biopsies, they could show that patient that received IVIG, the SV40 clearance was much higher in IVIG group. So again, we know that IVIG is routinely used in desensitization protocols and ABMR treatments, though the evidence is not so robust for monotherapy alone. We know also it is used routinely for highly sensitized patients to facilitate renal transplantation. If they are HLA antibody positive, then these patients receive IVIG on a regular basis, such that their cross-match becomes negative to facilitate their transplantation. And also, there is some hypothetical assumption that it may reduce the risk of de novo DSA formation in the context of reduced immunosuppression. So the other therapy I'm going to talk about is everolimus for BKV nephropathy. So this trial, this study showed that 10 transplant recipients with biopsy-proven BKV-associated nephropathy were converted from standard CNI exposure and mycophenolate to everolimus and reduced dose exposure CNI. Another 10 patients served as controls who had just reduced exposure to CNI, and they had reduced doses of mycophenolate. At 3 years follow-up, there were no graft losses that were seen in patients that were on everolimus and reduced TAC, but at least 5 out of 10 controls had a graft loss. Again, eGFR was much better in the everolimus and low TAC group compared to the other group. BKV replication also declined in the everolimus group, suggesting that BKV nephropathy may respond favorably to everolimus and low TAC. So again, this is another study looking at a similar outcomes to suggest whether everolimus leads to lower risk of BKV viremia. This is a prospective trial, a prospective study whereby the patients were of the 296 patients that were included in the study, 58 were prospectively treated with everolimus and low-dose cyclosporine, and another 238 with mycophenolate and standard dose cyclosporine. And these patients had sequential measurements of BKV in the blood. And it was shown at the end of the study, 57 patients had BKV. And of these 57, only 5 in group 1 that received everolimus and low-dose cyclosporine developed BK viremia, whilst 52 or 22% in the other group developed BK viremia. So suggesting that, again, low-dose cyclosporine and everolimus may be a better option than mycophenolate and standard dose cyclosporine. So these are all in the context of standard ABO compatible transplants. So what's the evidence in terms of ABO incompatible transplants because of the presumed high immunological risk status? Again, this study looked at 24 patients where 10 patients received everolimus with reduced dose TAC, and another 14 patients received mycophenolate with standard dose TAC. And at the end of 1 year, there were no differences between the two groups in the incidence of rejection or infection by using everolimus with reduced dose TAC. So it seems that even in ABO incompatible transplantation, everolimus with reduced dose TAC may not harm the graft. On the other hand, this study in the context of ABO incompatible kidney transplantation showed that switching from mycophenolate to everolimus will lead to improvement in BK viruria and viremia. So So just to summarize whatever I just spoke now. So here we have just the starting insult here is BKV. That is going to have an effect on the graft function, leading to graft dysfunction. And BKV is leading to reduced immunosuppression, and that can lead to induced rejection. And again, reduced immunosuppression could lead to de novo DSA formation that can lead to graft dysfunction. So using IVIG, everolimus, and low-dose TAC may actually counteract all of them. IVIG and everolimus helping the BKV, IVIG and everolimus and low-dose TAC helping the graft dysfunction, IVIG, everolimus, and low TAC helping to reduce the de novo DSA formation. So this was my thinking process when I started my patient on the management, which I'll share now. So as I have previously summarized, so this patient had BKV or in the context of ABO incompatibility and 6x6 mismatch. Despite reducing the dose of mycophenolate, his BKV titers were going up, and the creatinine sort of has remained high. In this situation, I stopped the mycophenolate and everolimus was started with a target of around 3, and TAC dose was reduced to maintain around 5, and the Wisslone dose was increased to 10 milligrams OD. And I gave him 70 grams of IVIG, and I repeated this monthly for 4 months in total. With this was a strategy. The creatinine started to fall a month later to around 1.35, and the BKV's load has come down from 240 million to 1 million and 1.5 million a month later. 2 months later, BKV became 30,000. 3 months later, BKV was not detectable, and the creatinine improved to 1.2. 6 months from the time of onset of BKV, I had done DSA, and it was negative for both class 1 and class 2. So in conclusion, this relates to an immunologically high-risk transplant recipient with BKV nephropathy who was successfully managed by conversion of mycophenolate to everolimus and low-dose TAC. IVIG was given prophylactically to try and reduce the risk of de novo DSA formation, as well as an adjunctive to treat BKV. I was looking up to see if anyone has done similar strategy, and it's obviously there is a trial that was being registered in the clinicaltrials.gov. This group from Boston are looking exactly with the same hypothesis, whereby they have used IVIG to reduce the formation of alloantibodies in the context of BKV when the dose of immunosuppression was reduced. The trial has completed recruitment of 24 patients, and it's not yet reported. Thank you.
Thank you, Dr. Pani, for your wonderful presentation and a journey through the BKV nephropathy. So, as you say that it is devil and deep blue seas, we are caught between devil and deep blue sea. And before start the ball rolling, what is the mode of action of mTOR inhibitors on BKV? How it reduces or inhibits BKV? Another my question is, you gave IVIG monthly for 4 months. Is there any standard protocol for that? So some people are taking a low dose of IVIG 10 grams every week for 4 months. So is that a standard protocol of monthly for 4 months? And what is the role of cidofovir? How have you used any experience of cidofovir?
Yeah, I think there's multiple questions here, but let me answer the question on IVIG. I think there is no standardized protocol here. Each one is using different based on their experience and the resources and the financial implications and various factors here. But what I know is if it's being used in the form of anti-inflammatory or immunomodulatory setup, we typically go for 1 to 2 grams per kilo per dose. On the other hand, if it is in the context of like say immunodeficiencies like CVID or things, then you may smaller, something like 0.1 grams per kilo per week, or some typically 0.5 grams per kilo every 3 weeks is what they use. So that's the typical observations are here. But again, this is such a small number of patients that we're likely to see, and to conduct a large clinical trial to understand what is the best dose is probably out of question, because I don't think we'll ever be able to achieve that. And in the context of whatever it is, as I said, financial implications of things, this I thought was reasonable to do. And this probably will not be feasible in patients that cannot financially afford. So luckily, this patient was able to afford, so I could propose. I mean, I sort of explained everything, the rationale behind it, and he was happy to go ahead with it. So that's one thing. And in terms of the role of mTOR inhibitors in the context of reducing the viral infections, I think it is not only, I mean, the evidence is not only against BKV, but also against CMV and adenovirus and other things. Again, I should be honest and say I am not entirely certain as to what the exact mechanism behind this is. I would probably have to pass this question. And I could certainly have a look and get back to you. One of the questions is pseudofovir. I think we have used in odd few patients in the past, but the only thing that I distinctly and very painfully remember is that it is pretty nephrotoxic, and that actually is worse than BKV nephropathy causing renal failure. So it's a matter of choosing again the devil or the deep blue sea. So pseudofovir has not got much evidence in terms of using with success in the treatment of BKV nephropathy, and it doesn't sort of occupy any space in sort of in the major what do you call as a major treatment option in BKV nephropathy.
Thank you, Dr. Mohan. Dr. Rushi.
Hi.
Hello. Yes, sir.
Yeah. Hi.
Your comments regarding his presentation and your experience on BKV nephropathy.
Right. First of all, Dr. Rajan, I should thank you for inviting me to this forum. It's wonderful to see all of you here discussing so nicely on these topics. And Dr. Serapani, fantastic talk. I'm sure that you must be having a decent experience with BKV. I just have a couple of points to add to what you said. One is, in a couple of patients, we changed from mycophenolate to leflunomide because it in vitro, it apparently has some anti-BKV activity. And that did help. Now, I don't know whether the reduction in immunosuppression worked or the leflunomide worked. And the good thing with leflunomide is that our rheumatology colleagues have a vast deal of experience with this particular drug. And it is not very difficult to use. We don't really have great literature with leflunomide in transplantation. However, say replacing with another anti-proliferative drug and with certain intrinsic anti-BKV activity, that's one thought. The second thing I would share is that when I had been to Tokyo Medical, all of us don't know Dr. Tanabe and the team. So they have this thing with mesoribine. And even though we don't get it here, that apparently is better for both CMV and BKV as compared to mycophenolate. So these are two thoughts. I think everything else that you said, I agree with, both for the IVIG as well as the mTOR inhibitors. And once you have a BKV, I think the other issue comes is when they lose the graft and you have to do a second transplant. And I don't know whether there's another right way to deal with that situation. What I personally do is you wait for some time with withdrawal of immunosuppression and see if the biuria dies down. If not, the role of graft nephrectomy is again debatable, though I have had graft nephrectomy in a patient with persistent viruria in 10⁶ numbers. And we did transplant the patient a second time. And so far things have gone well. But like you said, there is no perfect answer to give. It's all case-based, our own experience. Sometimes we burn our hands, sometimes we get a good result. So what is it that we share are basically happy experiences. But not all of them end up like this. And sometimes we do end up losing the graft, which is very difficult to handle, because we did everything right, went by all the levels that we normally follow, but some patients just get it. So I think that's my thoughts in a nutshell.
Thank you, Dr. Rushi. Yeah.
You have beautifully put it. Yeah, we sort of publicized the cases that went well, but there are equally bad experiences where despite doing everything right, it didn't work. I think that's a very valid point, sir.
Thank you. Dr. Rob Prabhakar, your opinion and your comments?
Okay, about BKV. I just want to ask one simple question about when to restart your original immunosuppression. Once you switch over to cyclosporin and the everolimus and clear off the BK virus, do you have the guts to go back to the original immunosuppression? Because at the end of the day, these two may not be an adequate immunosuppression if you want to keep a high-risk patient.
In fact, I have actually put him back on mycophenolate and TAC. I probably I think waited for another 3 months and he remained BKV negative. And I'm monitoring his BKV levels on a regular basis. So actually he's on mycophenolate and TAC now.
Do we have any literature data, like whether you should demonstrate 3 months or 6 months of consecutive no viremia before switching over, or it is just an abrupt?
I think, yeah, as with the most things with BKV, I mean, there are no guides. These are all just based on personalized therapies for the patients. And they definitely do recommend trying it once, the BKV virus has disappeared. But they also very, very clearly say that you have to continue to monitor for the recurrence. And if such a case, and if it continues to come back, then I think you'll be left with recurrence.
Sure.
Have you also come across any comparison data about ABO incompatible versus compatible in terms of BKV prevalence or incidence?
Certainly, the BKV nephropathy and CMV disease are definitely a little higher in ABO incompatible transplants. There is clear evidence to say that these are much higher in ABO incompatible transplants.
Yeah. Can I add something?
Yeah.
Yes, sir. Yes, sir. Go ahead.
Yeah. So I think that's an excellent question. The only thing I would like to add here is there any experience with quadruple immunosuppression in high-risk patients like this, where you don't take off the mTOR, the sirolimus or the everolimus, and you add low dose of MMF? Because ultimately it's a cumulative immunosuppression that would decide the resurgence of the DSA post-transplant. Any thoughts?
I
Sir,
have
you
considered that at some point.
Yeah.
You mean with the BKV patients or?
Yeah. No, so basically the holy grail here is to avoid BKV and also prevent resurgence of DSA.
Actually, whilst I was dealing with this patient, I had talks with Dr.Vel Arvind at the time. And his idea then was that it's going to be suicidal. So I don't know if he still shares the same views or not.
Actually, I can share with you that
quadruple therapy.
No, I have a significant number of patients on quadruple therapy, and actually they do well. I mean, just give it a thought.
Okay, that's
there's no, I mean, not like huge numbers, but I think around 20-25 patients for sure on follow-up.
Wow.
And what you do is you keep them on low dose mycophenolate, like 50% of your usual dose, and you don't take away the everolimus. Though definitely you can't have any valganciclovir at that time, because the biggest concern is leukopenia, and you have to keep a very close watch on the neutrophil count. So my threshold is 3000. Below that, I'm concerned to continue like this. But till then, I think it's quite okay to continue. Most of them do well. The resurgence of DSA is definitely lower. Because once you burn your hands with BKV, what else can you possibly offer? IVIG on an ongoing basis is not cost effective. And there are no other options available.
Dr. Rishi, is that sensible to have a leflunomide on board stopping MMF in place of MMF?
Yeah, so basically, that's what I said at the outset. In addition to everything that our speaker shared, the other two things are mezoribin and leflunomide. Leflunomide, though, the resurgence of DSA is not small. I mean, if you just follow these patients up and don't add anything else to it, right? Ultimately, these patients have failing grafts and the DSAs come back, or you do a biopsy and you find rejections. So leaving them like that on long term doesn't work.
Yeah.
I think the latest research is that of using viral specific T cells, which is a sort of cell therapy, and also anti-BKV monoclonal antibodies. I think these two therapies are still work in progress, and I'm sure that's probably going to change some of the way in which we treat BKV in the future.
Agree.
Yeah.
Yes.
Good. I had a few experience of BKV. Usually, I used to do that. I switch over MFMF to neflunomide, and I reduce TAG by 50%, and steroids has to be reduced. And quite a number of patients. We had around 15 patients of BKV still now, and around 10 patients I could able to pull along these patients without any BKV or development of DSA. For one or two patients, I had to start him on IVIG every second week, or 10 to 20 grams of IVIG every second week. And I continued for another 6 months. Ultimately, got rid of viremia. So experience varies, and it's again, it's not a clear-cut recommendations for BKV and all. So thank you. If no further questions, there is one question in the chat box, that is, there is any role of preemptive testing of BKV serology in immunologically high-risk patients?
I'm sorry, I didn't follow that.
Is there any role of preemptive testing of BKV serology in immunologically high-risk patients?
I think serology not have a. What you're probably asking is for a CR.
Yeah.
Measuring, because if you look at the
Dr. Pani?
Can't hear him so well, right?
Yeah.
Can you hear me?
Yeah, Pani. Yeah. Your voice is breaking. So, yeah. Go ahead.
Okay, no. So there are certain recommendations suggesting you do monthly BKV PCR for the first 6 months, and then at least 2 or 3 monthly after that for a couple of years. So yes, prospective testing of BK viremia, and they do consider sometimes copies per ml is considered to be equivalent to BKV associated nephropathy, whether you have biopsy or not. So, and once you find that there is a resurgence of the virus, then you start tweaking your immunosuppression down a little, such that it does not continue to rise. There are also people who do urinary decoy cells, but the sensitivity and specificity may not be great, and you need experienced lab technicians to identify those, and that becomes a little more difficult. BKV urine biruria may not add an extra advantage, because if they were positive, you still may have to end up doing blood PCR. So rather than doing, just a prick is the difference between urine PCR versus blood PCR. So I think it's better to go for blood PCR. And if the patients can afford, doing prospectively on a monthly basis for the first 6 months, and maybe 2 or 3 monthly after that is probably a good to prevent the development of BKV nephropathy.
Any role of vaccine? Is there any vaccine available for BKV? Is one question from the chat box.
No. There's not much point of vaccine, because typically in a healthy individual, it is kept under check by the innate and adaptive immune systems. But this only comes back when the immune system is suppressed. So even if you had a vaccine, that's still not going to work. So there is no role.
Thank you. So if there are no further questions, and let me thank Dr. Pani for this wonderful presentation of BKV. And thank you once again, panelists. And Dr. Sanjay has joined again. Shall we continue the presentation, sir?
First of all, I'm sorry that there was a technical glitch. So you can hear me, no?
Yeah. So you can continue your slides, and you can complete faster.
Sir, where did I leave it? By any chance, anyone knows?
Sanjay, you left regarding post-transplant diabetes mellitus.
Okay.
Oh, that's the slide you said something was interesting. That's the last word you heard from you.
Okay. I'll just come to that.
Yeah, please go fast.
Yeah.
Yeah, after this.
After this.
Yeah, when we looked at the complications, that is a post-transplant diabetes mellitus, see, early on the new onset diabetes, in both the groups when we compared, there are around 6 patients who developed it, compared to almost 9 patients in the conventional TAC. But when you go by the definition of PTDM, which is after 4 weeks of transplant, so only one patient in the OD-TAC had this, which is translating to around 4.17%, compared to 20% in the BD tacrolimus group. Now, we also looked at the infections, and when we look at the infections, mind you that in the OD group, we had induction for almost 13 patients, and only one patient had a infection in this group, compared to almost 10 patients in the conventional BD group. So this was, new finding which we are finding compared to all the other studies which were published before. And if you look at the patient and the graft survival, it was 100% for both patient as well as graft survival in both the groups, and there were no episodes of rejections in both the groups. Now, this is as far as the de novo use experience. This is the largest experience, I think, in India that I published. Now, then I looked at whether we have any data on conversion from BD tacrolimus to the OD tacrolimus as far as the Indian data is concerned. Then Dr. Sundar has got some experience. And he had around 44 patients which he had analyzed. And he has presented this in the other forums also. And you look at what we are looking at. Induction was done in almost 10 patients. And I'll just go to one thing which was different from my protocol was prednisolone was brought down to 5 milligrams at 6 months. I kept at 7.5 milligrams as the baseline. And here they started using azathioprine in a single dose in 4 of the cases. So reason for conversion was a rise in creatinine, high TAC levels, low TAC levels, delayed graft functions and others. But majority was because there was unexplained increase in creatinine in this group. So when he looked at the pre versus post conversion, what was the levels of the drug? You look, it is a major difference between the two groups. After he has converted it to Advograph group, the level seems to have settled down to the normal therapeutic range what we would want. And you look at the average creatinine remained the same when he was in Advograph converted compared to the BD dose that the patient was in. Now, one thing when we are using Advograph, we have to worried about is the fact that both are tacrolimus, and for a common man and for a pharmacist, it is just tacrolimus. So it is important that we tell the patient that Advograph is a single dose long-acting drug compared to other generic drugs which are available, which is BD. I have had at least 2 or 3 patients who are on long-term follow-up coming to me once in 6 months because they were already 3-4 years post-transplant. And these patients, when the tacrolimus was brought under rate control, from Advograph, they changed themselves to tacrolimus, which was done by the pharmacist where they were buying outside. And to a surprise, they maintained the levels in around 2 of these patients out of 4 patients, and other 2 patients had mild rejections, which needed to be treated. So this is important that emphasis should be given that both are not the same. Now, other thing that Dr. Sundar found was he was using single dose Advograph with 1 dose azathioprine, 1 dose prednisolone, all given in the morning. So, the feasibility of taking the immunosuppression was so good that he had around 10 patients who were taking all the triple drug, but it is only in the morning dose. So there was a lot of convenience with these patients, and I believe the patients were very happy. And these patients also had done well. So going by whatever data we have, the Indian data at present, so what are the insights that we get is that Advograph switch helps in reducing the creatinine levels in many of these patients where we cannot explain the cause for the creeping creatinine. And Advograph switch helps in keeping the drug level stable. It is easier because the patient is taking it only once a day. And finally, the major adverse effect is not there compared to de novo, compared to BD dose. When we are using it either de novo or as a switchover, it has a similar efficacy compared to the BD dose. Safety profiles are same. There is a easy conversion. Usually, if you see all the Western papers, they say that Advograph or a single dose would require 20% higher dose. But my experience and experience of Dr. Sundar says the same, that we are doing 1:1 conversion. We don't increase the dose of Advograph. It is simplified and easy conversion. And Adograph is comparable, I would say, to BD dose tacrolimus, but with my experience, it probably fares better with less number of infection, less chances of PTDM. I think we need to have more Indian data out of it, and we should come out of our comfort zone. I know BD tac is we have been using for donkeys years now. Probably use of OD track, we may be able to provide a longer graft life for our patients. Thank you.
Thank you, Dr. Sanjay, for your experience on OD TAC, which is a need of my actually. So my question is, one question to you. Does the difference in the induction between the OD dose and conventional dose has skewed our observation towards OD TAC? Is it so?
See, now if you look at the major difference that we found between the two groups was PTDM and infections. I would have expected more infection in the induction group compared to the BD dose. And second thing, we looked at the PTDM. And again, I would have expected PTDM to be more compared to the BD dose. But both the things were significantly lower in the OD TAC compared to the BD. Rest of the factors, we may say that probably it might have skewed as far as the safety and other, the number of rejection and all the other parameters are concerned.
Have you looked into the metabolizer status of the tacrolimus of all patients or for all patients?
No. We just looked at the levels.
Levels.
In fact, actually, to look at this, there is a belief that the evening dose absorption is less. Already, I have the paper, paper in the sense that the data which is getting analyzed for morning trough levels and the evening trough levels in the same day, same morning and evening for the same patient. So I will come out with the data very soon.
Thank you. Dr. Rishi? Dr. Rishi? Can you hear me? Dr. Rishi?
That is not here, sir.
Sir is not. Dr. Ram Prabhakar?
So, I'm not really convinced about the once daily tacrolimus, honestly, though it adds definitely significantly to the cost without major benefit for our patients. That is my personal opinion. There are two things when you use once daily tacrolimus, you should be aware of the metabolic phenotype, because in slow metabolizer, you may get away with little lower levels. So what I have seen in my personal experiences, whenever we use once daily tacrolimus, the trough levels falls. We keep increasing the dose. My experience is also you need 20 to 25% more dose when you use once daily compared to the BD dose. That's my experience too, although my experience is very little. Then about what I have seen is the comparison is okay when you use in a slow metabolizer. We may get away because tacrolimus is in rapid metabolizers, it reaches a rapid peak followed by a very profound fall. So when you use this once daily in rapid metabolizers, there may be problems that you may not get the levels, and we will have to probably keep increasing the Adograph dose. These are all my observations, and I'm really not convinced about its benefit compared to its cost. Probably once the cost comes down, I think I would probably switch over more. Regarding compliance also, I'm not really convinced, because we are anyway giving quite a bit of drugs in the evening also, though we may not use immunosuppression. So that are my personal opinions.
Yeah.
No, regarding with levels of the fast metabolizer, one thing is I started this patient -5, so I know the levels. Second thing is, it's a sustained absorption that the OD TAC has. If you look, first pass metabolism is very low in this, so the metabolism will not happen. And when you are talking about CYP, the overactivity which is causing this fast metabolizers, so you are avoiding that because the absorption is happening till the end of the small intestine, including up to the colon. So that problem, I think, is not very major.
Okay. Dr. Vel, with your experience? Dr. Vel is not there actually. So question. Okay. So is fast versus slow metabolizer, how flexible the dose scheduling is that we have discussed actually. So more received inductions in Advagraph versus BD-TAC, and surprisingly infections were less in the former. How can that be explained? That was a question.
Definitely, it was surprising result what I found because I would have expected more. And there was a question from Dr. Sachin Soni saying that why only one in the BD tag. Usually, I don't use induction, and when I'm saying unmatched kidney, I'm talking about spousal. So I don't use. We just give them the. This was a time when I was not using. This is in the 5 years back. So 5 to 6 years back. So presently also my induction is only on informed consent. We tell the patient the risks are less, but would you like to take or not? So if they agree for it, we go for it. Otherwise, for first degree relatives and spousal, usually it is not.
Okay.
And to explain why, I can only say that when you are taking BD tags, there are 2 spikes that the drug that comes. That is the only theoretical explanation probably that is causing over immunosuppression and the fluctuations. Otherwise, I definitely don't know the correct answer why the risk of infections were low. But I think we should look into it, the possibilities.
Dr. Vel, Arvind, are you here?
Yes, Raj, I'm just looking observing.
Okay.
I agree with Ram, actually. I go with first genotype. With any slow metabolizer, if I bring down TAC level below 1 milligram, 0.5 BD or 0.25 to twice daily, then that is a situation I consider definitely once daily. It may be useful. But otherwise, I'm a little skeptical and really fear about the rejection. I lost 2 patients, where I could not revert back to the normal things. That's my opinion. I think I thoroughly enjoyed his talk, and probably we can take some view from his side.
Yeah.
No, I think one way to avoid that, Dr. Vel, is that we started much earlier. Now you're going to put the patient on immunosuppression. So put them on immunosuppression and see what happens to the levels before you go for transplant.
I'm a little surprised you don't do stack as genotype, right? That's very worth Sanjay, so that you can understand slow, fast metabolizer. Even a fast metabolizer, how can you go with the level you said, right?
Yeah, I do it. See, ours is we work at a very low budget.
Yeah, that's
So
true.
for me, that's why. So I have a switch to what is called as a -5, -6 before I do the levels. So that gives me an idea what is happening.
Any tricky business, and we can't take it.
That answer. Yeah, Dr. Sanjay's presentation evokes interesting points, and we need to have a large number of trials, and you have to compare really the fast and the slow metabolizer. Probably your OD dose patients might be whole might be a slow metabolizer, so you are getting away with the thing. So anyway, it's an interesting presentation, and we should have the larger data to compare everything between OD and BD dose stack to come to the conclusion whether to go ahead with the OD dose stack. Dr. Rushi is there. Actually, your experience and your comments, sir.
Yeah, so I think my experience with OD dose stack is fairly limited. I don't have too many patients on OD stack. Maybe not more than 10 patients that I'm still started. But I mean, it does work well, I think. Never tried it in high-risk patients, though.
Yeah. For me, I have tried it for a patient, as Dr. Vel told. I tried in a couple of patients who received very lesser amount of TAC, like 1 milligram per day, and I got away nicely with that OD dose TAC. And I don't know about I don't have an experience on high risk transplant or fast metabolizer. So interesting, and with no other further questions, and it was an interesting sessions, and one with the OD and BD dose stacks, and both are practical, and it's not highly peculiar. They are all practical, and we have many take-home messages from both the presentations. And thank you, the speakers, Dr. Sanjay and Dr. Pani Gopalani, for their wonderful presentations, which enlightened us regarding this common scenarios which we are encountering. And thank you, Dr. Rishi Deshpande and Dr. Ram Prabhakar, for their wonderful insights into this presentations. And thank you, delegates, once again for your patient hearing and responses. And thank MQ team for your support. And we request the delegates and presenting many institutes to present the cases regularly so that we can learn with each other about the nuances of transplant. And thank you once again for joining us for this meeting, and hope to see you in the next month. Thank you very much.
Thank you. Thank you, sir.
Thank you.
Thank you.
Thank you, ma'am.
Thank you, sir. Thank you all.
Thank you.
Thank you, sir. Good night.
Thank you. Thank you, Dr. Rajan.